right. Well, welcome everybody. Hope you're having a great Friday. We have a wonderful webinar for you for the end of your week with Dr. Curt Ringhofer. We have creating value during the patient exam. I wanted to let you know if you have any technical issues while Dr. Ringhofer is going through his presentation, please just reach out in the chat. I'll do whatever I can to help you. Normally things on these Zoom live events, if there's a little bit of an issue or a buffer, it tends to resolve itself. But if it doesn't, please let me know. My name is Jerry. Reach out to me in chat. And if you have any questions, you can put them in the Q&A function, which is right by your chat function. And so without any further ado, it is my great pleasure to welcome to our virtual stage for you today, Dr. Curt Ringhofer.
Thanks, Jerry.
Welcome.
Well, good afternoon. I'm Curt Ringhofer, as Jerry mentioned. I'm part of the resident faculty at Spear Education. And just to give you a little bit of a history, I have a private practice in Orland Park, Illinois for the past 25 years. And over that time, it's really evolved into a practice that's focused on treating advanced restorative cases, especially with occlusion, TMD, and airway issues. And I was about a year out of dental school, and I remember sitting in a course at the midwinter meeting in Chicago, and there was a speaker presenting these beautiful restorative cases. And it was at that time I realized that I wanted to treat cases just like that. And so I signed up for these continuing education courses and learned how to treatment plan and treat the cases. But the problem I was having is patients weren't accepting the treatment I was recommending. And I went to a mentor of mine and I told him exactly what was going on. And he said, you have to create value to the treatment that you're recommending. So I started to learn more about value. So as you go through the definition of value, it's providing the consumer with the best cost, the best product, and the best service. Well, I understand the best product and the best service because, of course, I wanted to give that patient the Ritz-Carlton type of experience when they came into the office. But what confused me was the best cost, because I thought the best cost meant giving them the best value or the cheapest type of care. But it wasn't until I read an article with a quote by L.D. Pankey that said, a fair fee is the sum of money in which a dentist can perform their service and the patient will pay with gratitude and appreciation. And over those years, what I learned was patients will pay that fair fee if they value the treatment that you're recommending. And that's going to start with the new patient examination. As a matter of fact, what we call it is the new patient experience, because it doesn't start when we're treating the patient or when we're at the new patient exam. It starts well before that, typically with the new patient phone call. And either Natalie or Katie always answers the phone. How can we best help you at your first appointment with us? We want the patient to know right off the bat, we want to go in the direction that they want. We want to understand where they want to go before we recommend treatment of what we want to do. And I'm not going to get into the details of the phone call because all of you have different protocols that you go through to get information from the patient. But it's important that you end that phone call with the same type of message. Is there anything else you want us to know before your first visit with us? Again, reiterating that the appointment is going to be all about them. The next experience they're going to have and the impression they're going to have with your office is when they walk through that front door. The first thing it comes with is the office needs to be organized and neat. The way my office is laid out is when you walk up to the front desk, right behind there's a workstation. And there's times where they put UPS packages and things sitting there, and it drives me absolutely crazy because it's giving the impression of the patient that it's unorganized. So it's important everything looks neat, but the other thing is we want to welcome the patient. We want to welcome them by name and ask them if they have any questions for us. Oftentimes when Darren and I are in the occlusion workshop and we go through some of these things, patients say, well, how do you know that they're the new patient? Well, when we think about it, if it's someone we don't recognize, it's real easy to say, you must be Joe. We've been expecting you. It's welcoming the patient, giving them a different experience than they've had. And then it starts with the examination. Most offices are going to filter their new patients in through hygiene. But if you come in through hygiene, it's very difficult to create value because of the time constraints we have working in between patients. The example I'll give you is if we had Frank Spear and a dentist that's out of practice for 5 years. Frank Spear comes into a hygiene visit, looks in the patient's mouth, and because of his experience, he could probably look in the patient's mouth within those 5 minutes, know that what type of treatment they need, and recommend, let's call it $20,000 worth of treatment. But let's say the dentist that has less experience puts the patient through the new patient examination, like we're going to talk about, building value. The dentist they're going to trust more is the one that builds the value because they have trust with the patient. And that's what happens with the initial examination. Now, I did this early on in my career, and I've since transitioned to seeing every new patient in my chair first. And I'm not recommending that you have to do that, but what you will have to do is learn one dialogue. And that's, Joe, after looking in your mouth, we recognize there's more going on than we originally anticipated. And unfortunately, because I'm in between patients, I'm not going to have the time you deserve for me to explain everything. So what we need to do is reappoint you so I can give you that time and we can explain everything that we're seeing inside your mouth. Is that okay with you? When I was doing that, never once did I have a patient say, no, I don't want you to explain everything that you're seeing. So that's why I made the decision that I was going to see every new patient first before they got their teeth cleaned. When I remodeled my new office, I put a consultation room, and you don't necessarily have to have a consultation room. But what I'm going to recommend is that when you're going through that initial interview, that you make it very conversational. Many of these patients that need significant amount of dental work have a fear of the dentist. So if you're going to do that in the treatment room, keep all the dental instruments out of the way. Make sure that they're not feeling intimidated by it, because the new patient exam is going to create value that differentiates your practice from others. Frank Spear said this multiple times. He said, in order to recommend different type of treatment compared to other offices, you need to give them a different experience during that examination process. And that starts with the initial interview. The first question we ask is reiterating the same thing that was asked on the phone and when they walked into the office. How can we best help you at your appointment today? The next question, after they kind of go through what they're interested in, is, are you experiencing any pain, or have you had pain in the past? The reason why I want to ask that question early on is because from the time they scheduled their appointment to the time they came into the office, things can change. And when they change, it could be something's hurting them. And oftentimes, or I shouldn't say oftentimes, sometimes we need to shift gears, because what I don't want to happen is at the end of the new patient examination, the patient says, hey, doc, are you going to fix that tooth that's hurting? Now we're kind of stuck between a rock and a hard place, because my goal is to have the patient feeling good about themselves when they leave the practice. I want them to be happy. And if I tell them, no, we don't have enough time, they're going to be disappointed. But if I treat them and get them out of pain, the problem is I'm going to upset my staff. So by asking that question early on, we can shift gears, treat the chief concern of the patient, and then reappoint them for the new patient examination. I want to ask questions like, when was your last dental visit? When was the last time you had your teeth cleaned? By asking that in the initial interview before we're looking in the patient's mouth, it's just a question. But it's perceived very different if we ask that question while we're doing the intraoral examination. It's going to sound to the patient more like, when's the last time you had your teeth cleaned? It's very judgmental, and people won't feel good about themselves. We're going to let that initial interview go whatever direction the patient wants to go. There's specific things that I want to get answers to, and I'm going to ask those questions, and each of you have your own protocol for that. But before we go into the treatment room, I ask that question one more time. Is there anything else you want me to know before we go and start the process? And I'm quiet and listen to what they have to say. But before we go into the treatment room, I want to explain to them what's going to happen. And we're going to follow the aesthetics, function, and structure biology protocol. I'm going to tell them we're going to look at the way your teeth fit in your mouth and in your smile. We're going to look at how they function. Because Mrs. Jones, what we know is that teeth can be very stable and we can get them in the right spot, but a lot of the damage occurs when we're chewing and when we're clinching and grinding. We're going to look at the structure of the teeth. Are there any fractures? And lastly, we're going to look to see if there's any decay or any infections underneath the gum or periodontal disease. When we're all done, I'm going to ask permission to share with them everything that we found. And I'll say something like, Mrs. Jones, when we're done, we're going to meet right back into this room. And I'm going to take you on a tour of your mouth. I'm going to show pictures that show periodontal probings. And with the advent of intraoral scanning, we take an intraoral scan and we put that up on the screen. And I'm going to be quiet. And it's amazing how many times patients will say, ooh, what is that? Is that in my mouth? But we want to take them on a tour and we're going to number the teeth. And number 1 are teeth that need treatment. We're going to put number 2 next to teeth that are probably going to need work in the future. And number 3's next to teeth that are not going to need any type of work, or most likely not going to need any type of work unless there's some type of change in the way the occlusion is or opening up the vertical dimensions. But it's important after that new patient examination that the patient needs to understand their conditions and the risks associated with them. We talk about benefits of doing treatment and the risks associated with not doing treatment. I want the patient to understand enough so they can make a decision that's best for them. The other point that I want to make is it's important that the assistant reads out each area that's being examined. In EagleSoft, we have an Excel spreadsheet that goes through line by line all the things we want to look at. And Jeannie or Taryn, my assistants, will read out each line of that. They'll say things like, is there any decay? And I'll say there's decay on the mesial of number 18 and the distal of number 19. Please treatment plan an MO for 18 and a DO for 19. They'll ask about defective restorations. And if there's a defective restoration, I'll say number 14, DO. But we also want to look through structure. And also not only breakdown of the teeth, but is there some type of signs that could lead to breakdown? Do we have any sensitivity to hot or cold? Is there fremitus? Is there mobility in the teeth? Do we look at craze lines and we'll take an intraoral photo of the craze lines? Do we see any fractures and non-carious cervical lesions and the risks associated with those and how they could affect their teeth in the future? When we start to look at the aesthetics, we're going to follow the facially generated treatment plan. And that's a concept that Frank developed in the 1980s. First thing they're looking at is the maxillary incisal edge position and the vertical position. And typically that incisal display should be somewhere between 1 and 3 millimeters. We want to look at the horizontal inclination. Maxillary incisors often could be proclined or very vertical. We know that the incisor should be more proclined, and if it's off, the light's going to hit it differently, and it's not going to be aesthetically pleasing for the patient. We want to see how the transition is from the anterior to the posterior, and is there some type of stepped occlusion? And lastly, the reason for photos is we want to show them the gingival levels. This is Alyssa, and Alyssa came into the practice, and she was interested in getting the edges of the anterior teeth fixed. She didn't like how they looked, but she made no mention of the gingival levels. So what this photo allowed me to do was educate Alyssa on the things that should be there. And in the treatment planning workshops, they show a little template that you can show where the gingival levels should be. And Greg and Jeff do a wonderful job presenting that. From there, we want to find out, is there some type of altered passive eruption, and what do we need to do to treat the patient, feeling for the CEJ? And then you're going to repeat those same steps for the mandibular arch. But what we understood with Alyssa is Alyssa, by creating enough value for the treatment, she trusted the fact that I was going to treat her best. And we allowed us to fix and give Alyssa more confidence in her smile. And I apologize for the swollen gingiva. This is about 2 weeks post-op, and the gingiva was still kind of inflamed from the cementation. But where the rubber really meets the wheel is how the teeth fit together. It's pretty easy to set the teeth if we think about like denture teeth, and that's where facially generated treatment came from. But where teeth have a tendency to break is when they're functioning. And when we think about occlusion, we think about the teeth themselves. But we also have to evaluate the muscles and how that can affect if there's some type of breakdown in the teeth, how the structure of the temporomandibular joints can affect things, and how the airway can affect the function of the teeth. Because when we're teaching in the occlusion workshop, what the attendees typically want is they want more confidence in treating patients. And they want to understand if the patient is stable or there's some type of high risk when they're treating the patient or before they're treating the patient. So as we go through the different classifications of occlusion, the class 1 occlusion is where the teeth kind of match up in the ideal position. And those are really low risk patients. If there's some type of muscle problem, you can relax the muscles with cotton rolls or an anterior deprogrammer and get that seated position. The class 3 patient is more of the bulldog appearance. And I put them more at a moderate risk for treatment, not because of the way they function, because class 3 patients typically function in a vertical fashion, but it's the type of treatment that's needed to fix it. These are skeletal discrepancies. And when there's a skeletal discrepancy, it's going to include some type of orthognathic surgery. But the majority of patients that we see have some form of class 2. And when I talk to my orthodontic colleagues, what they tell me is that 50 to 60% of the patients they see have some level of class 2 occlusion. And these are the most difficult to treat because they don't have anterior coupling. And when we don't have anterior coupling, you're losing stability. It can cause extrusion of the mandibular anterior teeth or the maxillary anterior teeth. It becomes difficult to get guidance in the ideal type of manner. This could be important in the adolescent patient, but it also leads to a lot of struggles when we think about the adult patients, because it's much easier to treat the young 6-year-old with interceptive orthodontics, doing a rapid palatal expander or Herbst appliance. And as long as there's growth potential, we're able to gain the skeletal growth that we're looking for. But when we start to treat the adult patients, it becomes much more difficult. You have to do more surgical. You can hope that you can open up that mid-palatal suture with some type of micro-implant assisted palatal expansion. Sometimes you have to do surgical procedures like surgically assisted rapid palatal expansor or SFOT, surgically facilitated orthodontic treatment. But it's important that we understand where growth comes from, not only because of the adolescent patient, because of the adult patient. And when we explain to the adult patient how they got there or some of the possibilities of how they got there, it's going to build value. Because if we know how they got there, we know how to reverse engineer it. And when we reverse engineer it, it's going to lead to stability. And that stability is not only important for us, but it's also important for the patient because they don't want things to break down the way it did for their natural dentition. This article by Nebby said that when we're treatment planning adolescents, there's 3 major growth sites. It comes from the maxillary sutural system and condyle of the mandible in the dental alveolars. And it's my firm belief that if you get the maxillary arch and the mandibular arch to be in the right position, the dental alveolus is just going to develop correctly. It's just going to follow suit. It's when you have a growth deficiency in either the upper or lower jaw where the dental occlusion really becomes a problem. And when the dental occlusion becomes a problem, that's where we have instability in the system. Let's start with the maxilla. The maxilla is the arch that typically dictates growth as long as there's a healthy mandible and a healthy maxilla. Overjet and posterior crossbites are 2 of the more common malocclusions that you'll see when you're treating orthodontically. And typically that can come from a nocturnal mouth breather. So the question becomes, why are they breathing through their mouth? As a young kid, it could be from enlarged palatine tonsils. one of the things that always comes up is that the palatine tonsils will shrink as you get older. But what you'll learn in the airway process course by Jeff Rouse is that what is the effect it has not only on the occlusion, but what's the effect it has on the health of the individual as they get older or even as a young adult. It could be from large adenoids and lingual tonsils, the missing tonsils. If they can't close their mouth without suffocating themselves, they're going to have to be a mouth breather. Another reason that people become mouth breathers, or they can't, or the maxilla doesn't push the premaxilla forward or expand the maxilla, is because the tongue can't reach the roof of the mouth. And the way we're going to measure that is we're going to have the patient open their mouth to their maximum opening and then hold their tongue to the incisors and open again. That should be somewhere between 50 and 80%. And that's going to indicate that the patient isn't tongue-tied. If the patient isn't tongue-tied, by this looking at this illustration, you can see that the tongue is occupying the roof of the mouth. And when it occupies the roof of the mouth, like I alluded to earlier, it's going to push the premaxilla forward and expand the maxillary arch. And we're going to get normal occlusion from the maxillary arch. But what happens if the tongue can't reach the roof of the mouth, or the patient has to be a mouth breather? It doesn't want to live there. Well, then we lose the counteracting force from that the facial muscles are pushing on it, and we start to get collapse of the maxillary arch. Now, this is very difficult to evaluate. Difficult to evaluate because we can't climb inside the patient's mouth when they're closed. We could try to look at that with cone beam CTs, but a lot of times it's going to be dependent on where was the patient's tongue when you took the image. In our office, we always instruct the patient to put the tongue to the roof of their mouths and the tip of their tongue to the back of the incisors. But if the patient swallows or they don't follow our direction, it could become an issue. The easiest way to look at that is how are people developing? If you look at the patient on the left, she's got more of a prognathic profile. We can assume that she is breathing through her nose and her tongue is advancing the maxilla in the proper fashion. But if we look at the patient on the right, you can see she's got a very retrognathic maxilla and a retrognathic mandible. She was treated with some type of directive type of Herbst appliance. And because the inability for her mandible to grow, it actually pulled back the maxilla. It inhibited the maxilla from growing. And we're going to get into more of that when we start talking about the effects the temporomandibular joint can have on it. And Dr. Jim McKee does a great job of looking at that in the advanced occlusion course. But some of the other reasons that a patient may be breathing through their mouth is because the inability to breathe through their nose. This is where cone beam CT is really beneficial because deviated septums could be a cause. You can look at enlarged or hypertrophic turbinates. And if the patient has nasal valve collapse, where if they breathe through their nose constricts rather than opens up. But what we need to understand is that chronic mouth breathing during active craniofacial development can lead to anatomical changes that will affect not only the airway, but also abnormal orofacial growth. So when we look at patients like Debbie, when Debbie came into the office, she said she hates how narrow her smile is, and she wanted to fix that. She said, "Can you do veneers?" Well, if the teeth are in the wrong spot, there's no way veneers are going to give her the outcome that she's looking for. So by taking her through the examination, getting photographs and showing her why things might have happened, she then understood that we have to do something like surgically facilitated orthodontic treatment. We could try some type of MARPE procedures to get the expansion of both the maxillary arch and the mandibular arch. But by not recognizing this early, it also affected the health of Debbie. Using cardiopulmonary coupling, you can see how her sleep quality was very poor. The sleep quality index, which is outlined in green, should be somewhere greater than 55, and hers is 29. She's not falling into the restful level of sleep. When we look at the spectrogram, the dark blue peaks are parasympathetic activity. rest, relaxation, restore. When we look at the lighter blue or the royal blue, that's sympathetic hyperactivity. Sympathetic hyperactivity is causing inflammation in the system. It's causing stress to the system. And what Dr. Rouse talks about is how patients that have upper airway resistance syndrome, another way of thinking of upper airway resistance syndrome is ultra mild sleep apnea. It's not quantifying itself as an apneic event. But these are the patients that clench and they grind their teeth more. And when you clench and grind your teeth, you're holding your teeth together, and it can cause not only instability in the dentition, but destruction of their natural teeth or the work that we're doing. Dr. Christian Guillermo said that continuous interaction between the nasomaxillary complex and the mandible during nasal breathing is important to guide growth of the entire facial skeletal complex. And this was a little bit confusing to me right off the bat until I heard from a concept that was developed by Dr. Mark Piper. And he talked about the first molars being the smart molars. The maxillary and mandibular first molars are the first ones that erupt into the mouth. And in normal function, the maxillary arch is growing forward. And when the mandible closes, the distal inclines of the mandibular first molars are interdigitating with the mesial inclines of the maxillary first molars, driving the mandible forward, acting as nature's Herbst appliance. It's leading to distraction osteogenesis. When we have distraction osteogenesis and there's a healthy temporomandibular joint, the condyle is going to grow, which is another major growth center for dental facial development. But all of that is dependent on the health of the temporomandibular joint. If we have a structurally intact temporomandibular joint, your Piper 1 or 2, that's where you have protection of the disc on top of the condyle in any position of the mandible, whether it's in the seated position or in a translated position. You can have a structurally altered on the lateral pole, which is more of a moderate risk. You're still getting some protection of the articular cartilage, and in the young adolescent, the growth center, which is sitting on top of the condyle. The ones that are high risk are your structurally altered at your medial and lateral pole, your Piper 4s and 5s, because those have a higher probability of not having protection of the growth center sitting on top of it. But how does this affect all of growth and development? Well, let's go back to the illustration of the smart molars. If the mandible is not growing correctly, and the patient has, let's call upper airway resistance syndrome, and they're clenching their teeth together. Now, because the mandible can't grow, it's going to hold back the maxilla from growing and inhibit the growth of the maxilla. That's what happened to Kara, or what I'm assuming happened to Kara based on her history. If you look at Kara's facial asymmetry, you can see she's got a chin deviation towards the right. And when we look at her profile, you can recognize right off the bat that she is maxillary deficient, and she's also mandibular deficient. She was referred to the office because her occlusion was changing. There was instability, and she had pain while chewing. She spent 4 years in orthodontic treatment. She wore a Herbst appliance, and she had class 2 elastics. And I want to spend a little bit of time talking about those last 3. How long should patients be in orthodontic treatment? It's been my experience that they should be in ortho for somewhere between 1.5 to 2 years. And what we found is that when patients are in orthodontic treatment longer, it's typically because of a growth issue, a skeletal growth issue. And what the orthodontist is trying to do is get the teeth to couple. Because what's the ideal finish for an orthodontist? It's anterior coupling and the teeth to hold together. What the Herbst did in Kara's case is that because the mandible had the inability to grow, it actually held back the maxilla from growing, and there was retraction of both arches. So before treatment, she needed a cone beam CT and an MRI to get a proper diagnosis. But because of the pain, we went ahead and put her through the protocol of getting the imaging. And looking at the cone beam C panoramic view, you can see that she's 5 millimeters deficient on the right ramus height compared to the left. A lot of that has to do with the disc. That same study by Nebi said that the disc is responsible for the distribution of synovial fluid. Under compression, the disc will secrete synovial fluid, which lubricates the joint, which gives nutrition to the joint and gives oxygenation to the articular cartilage. In the adolescent patient, the articular cartilage is important to protect the growth center on the condyle. And in the article, it said internal derangements may be associated with altered craniofacial morphology because of a lack of growth. Disc displacements in adolescence can lead to early closure of the condylar growth center. And that's what happened to Kara. If you look at her MRIs, you can see that she's got an anterior disc displacement on both the right and left temporomandibular joints. Now, the question Kara asked, if both sides have an anterior disc displacement, why is the right condyle smaller than the left side? And that's one of the reasons why we need a cone beam CT with it. Because when we look at a cone beam CT, what it's doing is it's giving us a peek in the rearview mirror, kind of seeing where the patient came from. By doing different measurements of the condyle and different measurements of the temporomandibular joint, it's allowing us to see when things occurred. And when we look at the sagittal view and we measure the AP dimension of the right and left condyles, you can see that the right condyle is about 2 millimeters smaller than the left. That's an indication that the right condyle stopped growing first. So most likely what happened was there was disruption in the growth center that occurred before on the right side before the left side. So the left side continued to grow and the right didn't, shifting her chin more towards the right. I mentioned earlier that this can also affect maxillary growth. Dr. Drew McDonald and I came up with a concept called maxillary and mandibular triangle. And what it is it's taking a measurement from the condyle to the B point, which is right here on your chin. And if you look at those measurements on Kara, remember the right side had a shorter ramus height, and she's 4 millimeters shorter on the right when we take that measurement from the condyle to B point. But interestingly enough, when we look at the maxillary triangle, which is a measurement from the back of the joint socket to A point, and you'll see that it disrupts the maxillary growth as well. When there's a growth disturbance, especially in the young adolescent patients, these are the ones that you're going to affect growth on both the upper and lower jaws. So while the maxillary arch is important to stimulate growth of the mandible, if the mandible can't grow, it can inhibit growth of the maxilla. But how do we know when we should image patients? And that starts with evaluating the occlusion in the fully seated condylar position. This could be done in different ways. You can use a leaf gauge, you can use the Lucia jig, or you can use bimanual guidance. One of the questions I often get is, which one should I use? Which one's the best? Dr. Jim McKee did a study back in 2005, and he looked at the difference between using bimanual manipulation compared to an anterior deprogrammer. And what he found was when using bimanual manipulation, the repeated condylar position was within 0.1 millimeters tolerance, 33 out of 33 patients. When using an anterior deprogrammer, it was within 1.1 millimeters, 43 of 44 times. So the result of the study showed that there is no significant difference when you're using an anterior deprogrammer or bimanual manipulation. So from that standpoint, it doesn't matter to me what technique you use. What matters is we're evaluating the way the teeth fit together, because the importance of that is another concept that was taught to me by Mark Piper, and that's the rule of twos. And if there's greater than a 2 millimeter discrepancy in the horizontal position, measured from the incisal edge position of the mandibular teeth to the lingual contact area of the maxillary teeth, a 2 millimeter open bite measured from those same landmarks, or a 2 millimeter midline discrepancy, that is an indication that there's a higher risk of some type of structurally altered joint. So in the patients that have less than 2 millimeters, those are low risk patients for having some type of growth disturbance or breakdown at the joint level. 2 to 3 millimeters is more of a moderate risk. We need to consider that if we're consider imaging when we're doing more significant work, and greater than 3 millimeters is at high risk. But it's not building value is not just reading the bite, and it's not just taking a history. There's also other parts of the examination we need to go through. And that's going to be things like joint palpations, having the patient open and close, feeling for any type of clicks and pops. The Doppler is one of the tools that I use in the office on every new patient. And it's something different than they've never experienced in their office before. And it allows us to create value by the patient asking questions. What is that grinding noise? What is that click? What is that pop? And we do things like load test. Load testing is going to help us evaluate, is there any pain in the temporomandibular joints during function? But it also looks, is there any muscle tightness? But it's important that we understand and diagnose where the muscle instability comes from. And that can come from occlusal instability, from sympathetic hyperactivity. It can come from TM joint pathology. Sympathetic hyperactivity, because of poor airway, is going to lead to more clenching and grinding. TM joint pathology is going to change the occlusion. And because we're posturing our jaw differently, it could lead to muscle soreness. We go through a complete muscle examination. And the way I want the patient to grade it is with a 0, 1, 2, or 3. The dialogue I use is I'm going to go ahead and put my fingers on their shoulder and put light pressure. And I'm going to tell the patient, I'm going to go ahead and walk my fingers on some of these muscles. And if it feels just like this, I want you to answer me with a 0. If it feels like a sore muscle when you're getting a massage, that's a 1. Moderate discomfort is a 2. And if it hurts and you never want me to do that again, that's a 3. I'm not going to go through all the muscles we're going to palpate, but I do want to spend a little bit of time with the lateral pterygoid muscle, because in the past, it got a lot of attention. The purpose of it is to open the jaw and protrude the mandible. The reason it got a lot of attention was the thought was if there was a discrepancy between the seated position and there was a slide to MIP, the lateral pterygoid muscle was pulling the jaw forward, but it was also putting pressure on the joint, leading to a disc displacement. Well, Dr. McNamara did a study that said that the superior head of the lateral pterygoid muscle was not inactive during opening movements. And so that kind of defunct that theory. The actual purpose of the superior head is a positioning muscle that holds the disc on top of the condyle. Dr. Pete Dawson said, if you're going to quote me, date me. And Frank said it a different way. 20% of what I say is wrong. I just don't know what 20% is. So we have to understand that some of the concepts we learn today may change 5 years from now, 10 years from now. And we need to be able to change with that. In the advanced occlusion course, Dr. McKee goes through TMJ aware and TMJ directed patients. And this was a concept that was adopted off of the airway aware and airway directed by Frank. TMJ aware, these patients are indirectly evaluated through a clinical examination, and we're basing our treatment off a tentative diagnosis. We're not looking at things directly. But the TMJ directed patient, we're evaluating the temporomandibular joints with a cone beam CT and an MRI, getting an accurate diagnosis. And when we get that accurate diagnosis, it allows us to have a discussion on prognosis and give them treatment options. Because Dr. Piper said that the dentist and the patient need to know that ultimately the stability of the system comes from the temporomandibular joints. And if we want to predictably treat the patients with a stable occlusion, we have to make sure that the joints are stable. So when do we need to image? Let's look at Ryan. Ryan came into the practice as a referral from an orthodontist. And you can see he's maxillary deficient. And when we look at his midlines are off towards his right. First point of contact was on the right side. He had a 2 millimeter slide to his left, and he was maxillary and mandibular deficient. So we wanted to make him a directive splint to try to stimulate growth on the mandible. But before I did that, I needed to image to find out, was the growth center protected by the disc? And in the seated position, the disc was anterior displaced. And that's probably the answer why Ryan wasn't growing effectively. But the position I needed to evaluate was the class 1 canine, or where I was going to position his mandible, and that was underneath the disc. So we went ahead and made him a directive splint. And when I first saw Ryan in September of 22, his ramus heights were 50 millimeters on the right and 47 on the left. After 13 months of treatment, he not only grew 2 millimeters on the right side, but the left side caught up. Typically, we should get 2 to 3 millimeters of growth in the condyle in the adolescent patient. So two of the more common reasons to image is occlusal changes and pain. Pain can be a little complex because pain can come directly from the temporomandibular joint. Instability of the neck or the cervical spine could lead to instability of referred pain to the temporomandibular joint. And sympathetic hyperactivity from poor sleep quality could also lead to muscle tightness and changes in pain that could radiate up into the temporomandibular joint area. And it's our responsibility as dentists to determine where the origination of the pain is. Occlusal changes can be either from a failure to achieve normal growth, which we talked about throughout this entire presentation. It could be from abnormal growth in the maxillary arch, or it could be from the mandibular arch, or it could be from skeletal breakdown. This is Mary Claire, and we're going to talk a little bit about Mary Claire earlier, but when she came into the practice during that initial interview, I asked the question, is there anything about your teeth you'd like to change? She shared with me that she hates the fact that she has to walk around with her mouth open. She said when she was in high school, she'd walk through the halls and her mouth was open and everyone else's lips were closed, and it became embarrassing. And we're going to talk a little bit more about that in just a second. But to summarize, when we need to consider imaging, it's any patient that's experiencing pain in the temporomandibular joint, the pre-orthodontic patient that has a class 2 occlusion greater than 2 millimeters, and the adult restorative patient that has a class 2 occlusion greater than 2 millimeters. If we're going to do significant amount of restorative work and there's an anterior open bite, we owe it to our patients to help them understand if there's stability. That's what happened with Mary Claire. I mentioned how she was self-conscious of her teeth. And when we went through that initial interview, she told me that in first grade, if you look at pictures, her teeth, while they weren't overlapped, they did kind of meet end to end. And as she got older, that bite started to open. She has a history of locking, jaw locking and clicking and popping, and she has a significant overjet and open bite. When we put her through the imaging, you can see that her ramus heights were 62 and 61. But because their normal is somewhere between 60 and 70 millimeters, but Mary Claire is about 6 feet tall, and she should be probably on the higher end of that 70 millimeters. Her airway was at 38.2. So as we went through the process in the examination process, you can understand if she wants to close those anterior teeth, it's not just going to be orthodontic movement. We wanted to understand that the foundation or the temporomandibular joint is stable before we treat. So putting her through the MRI, you can see she's got an anterior disc displacement without reduction on the right and left side. And when she went into the translated or open position, she was bone to bone. So her parents and I agreed that we wanted to address the foundation because they were very smart patients, and they came in and they said, is it normal? I was reading articles and they asked, is it normal that there should be relapse of up to 5 millimeters after this surgery? My response to them was that relapse may be because the foundation wasn't stable. So we sent her to Florida to have a disc replacement by Dr. Brian Shaw. The process is he makes an incision right along the tragus of the ear, removes the disc, gets fat from the abdomen area, injects it into the capsule, and then the fat needs to vascularize for about 9 months before we go on to the next treatment. it almost becomes a callus. You can see that her airway went from 38 to 93 millimeters just by an increase in vertical dimension at the joint level. But remember, Mary Claire wanted to close her anterior teeth. So after we knew there was stability in the system, she went back to Dr. Shaw and he did a maxillary impaction, mandibular advancement, and a chin. If you look at the results of Mary Claire, you can see her profile is completely changed and she doesn't have that long face anymore. And her occlusion is actually closed. But the interesting thing was I talked to Mary Claire about 2 weeks ago and she's getting ready. We're going to take the brackets off and we're going to do just a equilibration just to get the occlusion to match up to the joints. And she said, I never realized how fatigued I was and how much better I feel now that I can breathe. And if you look at the effect that the surgery had on her airway, she went from 38 millimeters squared to 344.5 millimeters squared. That's a huge, huge advancement. And we were able to not only make her healthier, but we were able to get the teeth to close. The last case I want to talk about is Jill. And ultimately, what we all want to know when we're treating the patients is we want to know if there's stability in the system. And if we think about that, that's what the patient wants too. They may not say it that way, but when we build value that we understand if there's stability, that's when they're going to build trust. And when you build trust, the patient is going to be more likely to accept treatment. So Jill came into the practice because she cracked the lingual cusp of a tooth that had a large amalgam on it when she bit into a piece of candy. We went ahead at that appointment and removed the tooth and grafted it. But as we went through the new patient examination, I was asking her, is there anything about your teeth you'd like to change? She said, I always hated the color of my teeth. The history of this is she had crowns done about 20 years ago. 10 years later, a dentist wanted to make them lighter and they put veneers over the porcelain crowns, cementing them. You'll notice right off the bat that she's maxillary deficient and mandibular deficient. So when we went through the cone beam CT to not only evaluate the implant placement, to evaluate the foundation, you can see she's 6 millimeters shorter in the left ramus height compared to the right. But when we looked at the condyles themselves, they have pretty good cortication. So is there stability even though there's structurally altered temporomandibular joints? Remember, Jill wants to change her smile, and she's had these crowns on her teeth that had veneers done for 20 years, and there wasn't any chipping on any of the teeth. So when we went through the treatment plan presentation, I talked to Jill and her husband, and we went through the risks, the benefits, and possible outcomes. I explained to them that if there's changes in the back end of the system, it's going to affect how the teeth fit together. And we all agreed we were willing to accept that risk because of the history of stability in the past. But by bringing that up to them early, it's information, it's creating value that I understand the things that may happen. But if I brought it up after we treated her and things start to chip, then it becomes an excuse. And the patients lose trust in our ability to treat them. So in conclusion, the new patient examination is going to help the dentist and the patient understand their conditions. And if we can help the patient understand their conditions, it'll build trust, as I mentioned previously. The new patient comprehensive exam is going to create an experience that will build value. And once the patient values the treatment we're recommending, they are more likely to accept it. Now, I understand that in 45 minutes, it's very difficult to get a complete understanding of the concepts of the new patient examination and understanding if there's stability in the system to create the value. One of the resources that's offered at Spear is Spear Online, and it has hundreds of videos talking about the new patient examination. There's some from Frank, there's some from Greg and Jeff and Jim McKee talking about airway and the temporomandibular joints. And we'd also like to invite you to come on campus to a seminar. This Art of Treatment Planning seminar put on by Greg Kinzer and Jeff Rouse is a wonderful way to learn more about creating value during the new patient examination. And I know Jerry's going to post things that is going to give you more information. So at this time, I'd like to open it up for any questions.
There are a few questions. Well, one was about new patient paperwork and
New patient, what? I'm sorry, Jerry.
sorry, new patient paperwork. It said it's
Okay.
often a factor in coordinating their appointment, and they're looking for resources for that.
So if they want to email me, which is in the beginning of the process, I would be more than happy to go through that. But resources of it, I guess some of the questions I have is resources of the questions that's asked at the new patient exam. And those are things that we have kind of documented that I can share with them.
Okay, thank you. Um, it says, how do you treat palatal expansions in adults? Are there any limitations on age?
So that's a great question. And, Dr. Becca Baukow, who is also a resident faculty at Spear, kind of spearheaded MARPE, which is micro-assisted rapid palatal expansion. And when you go through the airway process course, in adult patients, a lot of it's going to be dependent. Can we break that mid-palatal suture? I think the latest is probably about 50–60% of patients, and don't quote me on those values, or percentages that actually will get some type of expansion. When patients are going through that, they're going to turn the key just as they would in adolescent. But the difference is it's more skeletal because the implants are placed in the palate. And when they turn the key, it's trying to stress that suture. And what patients will say is they'll actually hear a snap.
Hmm.
Now, if it works or it doesn't work is all dependent on how closed the suture is. Research shows that females are more likely to have that happen, and the younger we are, the more likely it is to happen. So palatal expansion can also be done by surgically assisted, where a surgeon will kind of make a slice right down the mid-palatal suture and then go ahead and advance it either with the implants or tooth-borne. So either one is a way to do it. Obviously, if the micro-assisted rapid palatal expansion doesn't work, then you have to go to something that's more surgical.
Okay. Um, did or do sleep apnea patients statistically have some kind of malocclusion?
So a lot of it depends on, are they mouth breathers as a young adult? The effects of things. And so that's a tough question because, typically they are more prone to it. I'll use that word, but all or nones are very difficult to state. Just because you have sleep apnea doesn't mean you'll have a malocclusion. But what I've recognized or noticed in my clinical experience is that if it starts at a young age, then we need to determine, is the airway problem because of some of the things we talked about, enlarged tonsils, adenoids? One of the things that I've learned is that if there's wear on primary teeth, most likely that's because of an airway issue. Upper airway resistance syndrome is where patients are going to grind more. And if kids are grinding, there's usually some type of disturbance. And those kids may be the ones that have some type of malocclusion. The other reason could be because of some type of injury to the temporomandibular joint that caused an anterior disc displacement, which led to a failure to achieve normal growth at the joint level.
Okay. Let's see. How long did rehabilitation after airway surgery take for, was it Mary Ann?
Mary Claire?
Marie Claire, yes. And how did the patient go through it easier?
So Mary Claire she's just an unbelievable patient. And she calls and gives me updates on things. And as she was going through the process with Dr. Shaw. So after we got her initially evaluated, she had the joint surgery, and that was the disc replacement. So that takes 9 months to assure that there's stability at the back end of the system or the temporomandibular joint. Then she went through the normal dual jaw surgery. So from start to finish, she was probably a good 3 years to where she's at now, just getting the brackets off, and we're going to do just a brief equilibration. Dr. Shaw did a great job of doing the dual jaw surgery, getting the teeth to match up correctly. So there's very minimal work that I actually have to do, but it was just a fun case to work on. Now, remember, it wasn't airway initiated by Mary Claire. It was because her mouth was open. The reason I pointed out the airway changes is because when she started treatment, she was about 19 years old. And as we get older, we become more apneic. So it's setting up Mary Claire for a healthier life. Now, again, all or nones are not fair to talk about, but is she more prone to some type of airway disordered breathing because of her small airway? Absolutely.
What does Jeff Russell say? The young fit female versus the the
Old
older
fat
fat
male.
man, old fat man.
Yeah. And the
Those are the
young fit
big,
female are the ones that typically, and the kids are the ones that grind more.
yeah.
What you'll learn from Jeff is that as they become the old fat male with severe apnea, they're not grinding their teeth anymore. They've worn that out. It's burned out.
Burned out of them. But so it wasn't so much something mechanical or procedural to help her go through it. It was just her biology took well to the treatment.
Yeah, I mean, and the first thing that we needed to do, and Dr. Shaw, was to make sure the foundation was stable. And the reason why we wanted to do the joints first is because of some of the articles that actually Mary Claire and her parents found that showed that there could be up to a 5 millimeter to 10 millimeter relapse after joint or after orthodontic surgery. And I think some of those studies weren't looking at the joints. And if there was instability at the joint and there changed the position of the condyles, it could lead to breakdown of the condyles. And then that's going to, I don't know why my screen just did
Your
fireworks.
your screen was celebrating.
Yeah. The so that by understanding that the foundation is stable before doing any type of occlusal treatment, whether it's restorative treatment, I showed that case because it's extreme, but think of it a lot like if you're going to tear down an old house and the foundation is crumbling, you could build $1 million house on that foundation, and windows are going to crack and doors aren't going to open and close the same because the foundation isn't stable. And that's what the temporomandibular joint is, the foundation.
Do you have any recommendations of written materials covering growth and development? The question is specifically covering growth and development with applications.
So there's all kinds of articles that I could share and give you, the articles back from the 90s with Nebby, Flores Mir, resources on Spear Online with Jim McKee are awesome, and he's got all kinds of references on there. But if they want to email me, I can get some of those articles and give you the titles and references for that.
Awesome. And McKee's got great classes as well online.
Oh,
And so does Rebecca Backow. They, they
mhm.
they both will probably have some, especially on growth and development for specifically that question. I
Yeah,
just
Becca's got more of the maxillary growth, and Jim talks more about the mandibular growth. And
yeah,
quite frankly, we need them both to grow to work correctly. To
yeah.
do what we want to do is restorative dentistries, or in restorative dentistry, because I mean, if there's a skeletal problem, that's ultimately going to lead to getting the teeth to match up correctly. And if we can intervene earlier, like I alluded to earlier in the presentation, that's going to make our lives easier. The teeth need to be in the right spot. And Frank's been talking about that for years. When the teeth are in the right spot, we can restore it.
Can treat easier. Two three-dimensional objects that you're manipulating over time with each
Mm-hmm.
other and their relationship with each other. Well, um, that's all the questions that we had. I went ahead and put a reminder in the chat of your email if people want to again reach out with some more detailed questions, or if they want to look on Spear Talk for some more deep dives.
Yes.
Wonderful. Well, thank you,
Awesome.
Dr. Ringhofer. Thank you, everyone, for
Thank-
joining us today.
Yeah, thank you for coming. And if you guys need anything, please don't hesitate to ask.
Is there any final thought, and message from today's presentation to leave them with?
I think, I started off the presentation with right out of dental school is when I thought to myself, I want to treat more advanced cases. And, for me, doing tooth dentistry just would be too mundane. And my practice is, I'm a general dentist, so my practice is probably 70% of it is just day-to-day dentistry. But what excites me is when we get these cases like Mary Claire or Jill, where we can do more advanced dentistry. But the fear comes when we don't know if it's stable or not. And where we build value is during that new patient examination. And it took me years to understand that that new patient examination is what creates that value. And once the patients value your treatment, they're going to be more likely to say yes because they trust you. Value comes with trust. So just keep forging on, and I think you're gonna enjoy dentistry much more when you understand how to treat these advanced cases.
Wonderful. Thank you very much.